Hello, I'm Keith Fox, and here we are at the European Society of Cardiology in Munich. We have a really exciting day today. I'm here together with Stefan Achenbach, who's chair of the program. Stefan knows more about the program than anybody else, but you've been so busy you haven't been able to get to every session.
That's true, Keith. That's absolutely true.
And I'm here with Brian Williams, and it's really important because Brian has chaired the guidelines on hypertension, one of the key guidelines that's come out today. And so what we're going to be doing is discussing some of the key papers and presentations that are making waves today. So let's start with hypertension. Brian, you told me that you had 200 pages of comments that you had to deal with.
Yeah, I mean, it's such a big topic, and it cuts across so many areas of cardiovascular medicine, cardiology, pharmacology, etc. Huge interest, and the session today was absolutely rammed. It's really, really spectacular.
So a lot of interest, but for the practicing cardiology person, what are the key take-home messages?
So we haven't changed the classification of hypertension, which is of course what the Americans did and dropped the diagnosis threshold to 130 over 80. We kept it at 140 over 90, and that's really important, I think, because there was no justification in our view to make that switch. In terms of the treatment thresholds, one thing we have done is lowered the thresholds for older patients because the evidence is suggesting that people over the age of 65 certainly benefit being treated at 140. And there was some uncertainty about whether they tolerate it in the risk-benefit balance, but it's absolutely clear now they benefit. People over the age of 80, we still say 160 because we've only got one trial and we really don't know the benefit risk-harm ratio in that particular population. But the message is everybody above 140 now gets treated with lifestyle and drug treatment.
And the key part of this message for the wider community is, in older age, treat people with thresholds that hadn't been well established before.
Absolutely, and there's no reason at all why you shouldn't treat elderly patients for hypertension because it dramatically reduces the risk of stroke and heart failure.
Right.
They're the two major things that are reduced by that particular treatment. The other thing, Keith, that was really big in the story were two things. Was the targets, because we had quite conservative targets in Europe, and as a consequence of a number of studies, we basically said, if you are under 65, get blood pressure below 140, aim for 130, and if you can get it lower, that's going to be beneficial for the patient. But don't aim to go below 120, that's too low.
Because we know from studies that hasn't worked.
And then if you're over the age of 65, up to any age, go below 140 if you can, monitoring tolerability, but don't generally go below 130 because we know that as we get much older, the tolerability, particularly renal tolerability of big reductions in pressure is not good.
So Stefan, anything you want to add in terms of this guideline or the other guidelines?
Indeed, I think I had the impression that beta blockers have sort of fallen out of grace a little bit compared to previous versions of the guideline.
So the other big message we've tried to address is, and we've changed treatment radically. So there's been a lot of different combinations over the years. We've basically said three things. One, start treatment in everybody with two drugs, not one. One drug.
That's an important change.
It's really important because one drug doesn't work. But if you are going to use two drugs, patients don't like taking two pills, start with a single pill combination. And if you need three drugs, single pill combination. So we've called it a one pill strategy to treat blood pressure, and that will control 80% of people.
Terrific. And this is a big change from what's existed, 5 years ago. So let's move on to some of the hotlines from today. And in a key hotline session, there was a lot about aspirin.
There was quite a bit about aspirin. We had two studies, ARRIVE and ASCEND, both addressing aspirin for primary prevention. That's the question here, whether we should be taking aspirin to prevent the first cardiovascular event.
So ARRIVE was in individuals over the age of 40 with diabetes.
Yes, indeed. And the question is whether these diabetic patients, high cardiovascular risk obviously, benefit from taking aspirin. And the effect of the trial, 12,000 patients followed for 7 years.
Yes.
The trial started in 2005, so long-range study. Trial was negative. The overall endpoint, as far as I have in mind, is about 8% event rates for vascular events was lower by 1% in those who were taking aspirin, but the bleeding rate was 1% higher.
It was major bleeds up by 1%, vascular events down by 1%.
Exactly. So and the vascular events was about 8%, the bleeding events were about 4%, but the difference was 1% in both groups. So they was balancing it out each other.
Okay. So there was also the ARRIVE study from New England, Boston area,
Yep.
and these are people, again, primary prevention at moderately high risk.
And once again, no significant benefit of aspirin could be found. It's again the balance of preventing events and bleeding. The rates overall were lower, the event rates were lower, the bleeding rates were lower, but there was no significant benefit of taking aspirin. Some sub-analyses were done, and for young individuals, the rate of myocardial infarction was, if you did the sub-analysis, significantly lower, but overall the endpoint, no significant benefit of taking aspirin in primary prevention in these individuals with moderately elevated cardiovascular risk.
And that's consistent with most of our guidelines,
Yes.
isn't it? That primary prevention, no aspirin, secondary prevention, aspirin.
Now have we...
They had a problem in the trial,
Yes.
though, and they had a problem with compliance. And not so much that people would drop out of the Verum group, but rather that people would drop in, as they say, right?
Yes,
They would, by their physicians, those in the placebo group would be put in aspirin, so that at the end, more than 40% actually did not follow the originally prescribed treatment.
Yeah, so that's a really important set of studies. In the same program, there was an investigation of, again, omega-3 fatty acids.
I think you can cut it very short.
Can we put this to bed?
Yeah, we can put it to bed. No effect, no benefit of omega-3
No
fatty
benefit,
acids.
no harm.
Yeah.
So a lot has been spent on omega-3 fatty acids. Let's put it to bed. Okay, now what about weight? Because there's been, across many countries, problems with increasing prevalence of diabetes type 2 and obesity. One presentation on a 5-HT2C, in other words, a serotonin receptor blocker to suppress appetite, Camellia. What should we take from that?
Well, the Camellia trial, looking at a weight loss drug, I think it can easily be misunderstood. The trial was not conducted to find out whether a weight loss drug would decrease cardiovascular events. It was much rather conducted to take away the worry that taking this weight loss drug might increase cardiovascular events, because previous drugs had increased cardiac event risk, and the FDA now requests for these drugs to have a trial that shows that there's no cardiovascular event risk. And this was again a 12,000 patient study, randomized to taking the weight loss drug lorcaserin or not, and there was no difference in cardiovascular events in those two groups. So there was no benefit from the weight loss drug. The people on medication lost about 4 kilograms. The people off medication with exercise and diet lost about 1 kilogram. No outcome difference as far as events are concerned, but also no damage done by the drug.
Did they look at pulmonary hypertension as well?
They did echo studies. They did in those 12,000 patients, not in every patient, but they had subgroups of about 4,000 patients who underwent echo. A total of 20,000 echocardiograms were done for the study. They could not find pulmonary hypertension or mitral regurgitation. It was a small signal, non-significant, towards aortic regurgitation, and the trial was only 3 years. So maybe if we wait longer and do echo carefully, something can be seen again, but at least not a big impact on valvular disease, pulmonary hypertension, which was sort of to be worried about after the Fen story that we had.
So on the theme of imaging and coronary artery disease, does it help to be able to diagnose coronary artery disease in people with stable angina with CT?
You are alluding to the Scott Hart trial,
Yes.
Keith, and the Scott Hart trial, I think, shows very clearly that seeing, let's put it that way, seeing atherosclerosis in the coronary arteries will help. This was a 4,000 patient trial done, 2,000 patients randomized, patients with suspected coronary disease, 2,000 of them randomized to have standard workup plus CT angiography, and 2,000 only standard workup. And we had seen 1-year results, 2-year results, and now 5-year results. And the early results had already indicated that adding CT angiography might reduce myocardial infarction, a combined endpoint of cardiovascular death or coronary artery disease death and myocardial infarction. And now we have 5-year income shows the same thing. The combined rate of cardiac death and myocardial infarction is significantly lower in those who had a CT scan. Death alone, no difference, but the combined endpoint was different. The question now is why? And it's very interesting because the trial was initially criticized that those who had a CT scan had more invasive angiograms, more revascularizations. And it shows that after 5 years, there's a catch-up phenomenon.
There's a catch-up, yeah.
After the 5-year period, exactly the same number of invasive angiograms, exactly the same number of revascularizations in both arms, yet still, those who had a CT have lower event rates. And the reason is not the revascularization, the reason is the medication.
Yes.
There was a higher amount of individuals placed on risk-lowering drugs, statins, aspirin, in the CT group than in the conventional group, and that's what made the difference.
And I guess it raises the question as to whether coronary CT calcium should be regarded as definitive evidence of plaque as an indication for statin.
Yeah, it's
that's a bigger issue.
Exactly. Yeah. It's not calcium, it was a CT angiogram, so it's a slightly more elaborate test. And we should not only say more patients were placed on medication, maybe it's the right patients who were placed on medication. Perhaps,
yes. Okay, so that's... Now, there's also in the intervention field, the long-term outcome of culprit shock. Culprit shock, we've seen previously 30-day results. Mm-hmm. This is the issue of doing just the culprit vessel or multi-vessel, and the primary endpoint was the combination of death or renal replacement therapy. What are your thoughts, Stefan?
Well, the trial that's a 700-patient trial, and it shows that our results in patients who have myocardial infarction and shock are dismal. We had, after 30 days, about a 50% combined endpoint rate of mortality and renal replacement therapy in both arms approximately, and there was no benefit to multi-vessel revascularization. In fact, there was a damage by multi-vessel revascularization. And now we have the 1-year results, we see the same thing. No benefit to multi-vessel revascularization. The recommendation really has to be that only the culprit vessels should be revascularized in general in patients who come in with MI and cardiogenic shock.
Right, so there's an important clinical message.
Oh, absolutely.
So we've had 32,500 people registered here already. I can tell from looking at the sessions that are packed in standing room, it's been terrific. There's been excitement, there's been a buzz all round. And in the morning, you and I are going to be discussing the breakfast buzz and a chance for people to have questions. Any final comments, Brian, from you and from Stefan?
Well, I really enjoyed the Congress. I think the guideline session this morning was terrific.
Terrific.
And it's really good practical information for cardiologists.
Yeah, take-home messages, terrific.
I would agree completely. It's a practical Congress, it's a clinically oriented Congress, very high amounts of clinically relevant information in the guidelines, in the scientific sessions, and people seem to be happy, as you say, Keith.
So see you in the sessions, see you online. Thank you very much.